Why can oxygen, which is life-saving, be harmful in some COPD patients? Or why we keep a target SpO2 of 88 to 92% in COPD patients or sleep apnea patients? And if the famous hypoxic respiratory drive, is it completely true or partially a myth? So friends, in today's video, I am going to explain the concept of hypoxic respiratory drive, which will be very important for you while managing the patient of COPD or sleep apnea syndrome. So friends, you watch this video till the end, and if you have come for the first time on this channel, then do subscribe this channel for more such clinical videos. So friends, let's start. So to understand the concept of hypoxic respiratory drive, we should first know the normal control of respiration. Most of us think that oxygen is the normal stimulus for respiration, but it is not true. The real stimulus for respiration in normal conditions is PCO2, that is rising carbon dioxide in the blood. So when the carbon dioxide rises in the blood, it ultimately leads to the rise in the H ions or fall in the pH in the CSF, and this stimulates the chemosensitive area, and which ultimately stimulates the inspiratory area, and in this way the respiration is stimulated. Now, where is the role of oxygen here in normal respiration? The oxygen comes into play when the PO2 it falls below 60. When PO2 falls below 60, the chemoreceptors present in the aortic bodies or carotid bodies, they are stimulated, and then via the vagus nerve or the glossopharyngeal nerve, the respiratory areas in the medulla are stimulated. So in normal healthy individual, the main stimulus of respiration is rising carbon dioxide in the blood. Now, what happens in COPD patients? In COPD patients, because of airway obstruction, there is chronic rise in CO2 levels in the blood. And due to this, the body gets adapted to the persistent rise in the CO2 levels, and the chemosensitive areas, they become less sensitive to carbon dioxide. And hence now these patients, they depend on the oxygen or rather low oxygen levels for their respiration. And this is called as hypoxic respiratory drive. So the patients of COPD or sleep apnea syndrome, their respiration depends upon the hypoxic respiratory drive. Now let's see a common case that we often face in the ER. So this is a COPD patient who arrives breathless in the emergency room. Some junior doctor starts with high flow oxygen at 15 liters per minute, and after some times patient becomes drowsy, CO2 in the blood rises, and there is respiratory acidosis. And what we are traditionally taught, we are taught that giving high flow oxygen, it removes the hypoxic drive and the patient stops breathing, and due to which there is rise in the PCO2. But this explanation of hypoxic respiratory drive is not so simple, and it is very complex, and it involves various types of mechanisms. So now we will see what are those mechanisms. So the first and the most important mechanism is of VQ mismatch or ventilation perfusion mismatch. So in COPD patient, some lung is normally ventilated, and due to airway obstruction, this is airway obstruction, due to airway obstruction, some lung is not properly ventilated. So this is about ventilation, and now let's see about the perfusion. Now this is heart. Now example for sake of calculation, consider there is 100 ml of blood in it. So where there is normal ventilation, about 80% of blood goes through this artery, and only 20% of blood goes through the part of the lung which is not properly ventilated, and this is called as hypoxic pulmonary vasoconstriction. This is called as hypoxic pulmonary vasoconstriction. Now, when you give 100% oxygen, now you have given this patient 100% oxygen. Now, what will happen? The oxygen in this poorly ventilated alveoli, it will increase, and due to it, the hypoxic pulmonary vasoconstriction is lost. Now, about say 40% of blood is flowing through the poorly ventilated lungs. But since the lung is poorly ventilated because of the obstruction, though the oxygen in the alveoli is normal, the exchange of CO2 is not normal, and hence the blood that is coming out through this area, it will have more CO2 or increase in the pCO2, and this is the main reason when we give increased oxygen to a COPD patient, there is rise in the carbon dioxide levels. So this is the main mechanism, that is ventilation perfusion mismatch. Now the second mechanism is due to Halden effect. Now this Halden effect says that when the hemoglobin is oxygenated, it has less affinity for carbon dioxide, and when hemoglobin is deoxygenated hemoglobin, it has more affinity for carbon dioxide. So when we give large amount of oxygen, the oxyhemoglobin increases, and since it has less affinity for CO2, that CO2 is released in the blood, and this is the another reason why there is increased pCO2 when we give more oxygen to the COPD patients. So, though the proper explanation of hypoxic respiratory drive is partially correct, but the main mechanism is, one is a ventilation perfusion mismatch and the other is Halden effect. So now what you should do if a patient of COPD comes to your hospital and saturation is 70%? Should you not start oxygen to this patient? Let's see what you can do. So never withhold oxygen to a hypoxic patient even though the patient is of COPD. Use a controlled oxygen therapy. You should use a Venturi mask, or if there is no Venturi mask, you can use nasal prongs with very less flow rates of oxygen. You should target the SpO2 of 88 to 92%. This is very important. And when in doubt, if you have doubt that patient is retaining CO2, then immediately you should do ABG. Now, when should you use a BiPAP or non-invasive ventilation in a COPD patient? If there is rising pCO2 in the ABG, if the patient is becoming drowsy, or if there is respiratory acidosis or increased work of breathing, in those conditions, you should start with NIV. So the four important points in the summary are: CO2 is a primary respiratory stimulus in healthy individuals. Hypoxic respiratory drive is important in chronic retainers of carbon dioxide. VQ mismatch is the major mechanism behind rise in the CO2 after starting oxygen. And controlled oxygen therapy is the key in the treatment of hypoxic patient of COPD. So after listening this video, you will be confident in starting oxygen therapy whenever a patient of COPD will come to your hospital in hypoxia. If you find today's video useful, give it a like, share with your friends, and if you have come for the first time on this channel, then do subscribe this channel for more such clinical videos. See you in the next video. Till then, thank you.